Low backache is a common cause of morbidity. This short presentation provides an overview of the causes of backache, provides inputs as to how we can manage backache without surgical intervention, and also on the rationale behind surgical procedures. Let us understand a few terms. Lumbago is low backache of spinal origin. Sciatica is a pain radiating to the leg, which indicates compression of a nerve coming from the spine and going to the leg. Claudication is pain radiating to both lower limbs on exercise. Of course, there are two kinds of claudication, neurogenic and vascular. Vascular claudication is because of a narrowing of the arteries. And neurogenic claudication is because of a little compression of the nerves, where the blood supply to the nerves becomes impaired. So here, when the person exercises, there is relative ischemia along the nerve and pain syndromes occur. Cauda equina syndrome includes bilateral ankle weakness, bladder bowel involvement, and saddle anesthesia. A few neurological signs, the commonest ones, a foot drop where the ankle dorsiflexion is impaired, is because of a L5 nerve root involvement. An absent ankle jerk indicates an S1 root involvement. And an impaired straight leg raising test, SLRT, shows entrapment of an existing nerve root, commonly at the exit foramen of the vertebra and most commonly due to a disc prolapse. What are the causes of lumbago sciatica? The causes of pain can be instability of the spine. It can be an inflammation, especially of articular surfaces, and it can be because of nerve compression. So instability, inflammation, nerve compression. Degenerative spine disorders are wear and tear disorders which occur as a person gets older, but not directly proportional to the amount of activity. In fact, it is less common in active people than in relatively inactive people, similar to osteoarthritis of the knee. I'm a marathon runner, I don't have osteoarthritis. My colleagues who have been pretty well couch potatoes often suffer from osteoarthritis. Degenerative spine disorders include osteophytes grow, they press upon nerves, the disc gets degenerated, dehydrated, and tends to bulge, which can result in neurogenic compression. The ligaments become lax. As the ligament laxity occurs, there is abnormal movement which makes articular surfaces inflamed. There is hypertrophy of the ligaments also, which might press upon nerves, producing radicular symptoms. Osteoporosis can result in fractures with trivial trauma suspected, especially in older people and older women more particularly. Trauma produces wedge compressions of the spine most commonly. In most of these cases, especially if the compression is less than 1/3, or you can even say half, the pain might be relieved by conservative measures, but more than 1/3 compression, very often you might require stabilization, especially in the lumbar region, because the dorsal region has got the additional support of the rib cage. Burst fractures more likely to require stabilization because of a risk of retropulsion of fragments. Avulsion fractures are not because of direct compression, but because of muscle attachments getting pulled. Usually affect the transverse process or the spinous processes. Tumors can also produce back pain. Bone tumors, metastases are the most common, which are outside the dura, outside the neural elements and the covering. You can have intradural extramedullary tumors, most commonly neurofibromas and meningiomas. You can have intramedullary tumors which produce a different kind of pain, an aching, vague pain, which can be because of stimulation of the tracts. Infections which produce pain include tuberculosis of the spine. Disc space infections are very severe pain producing, and it might be even spontaneous or sometimes can occur even after spinal anesthesia and injection and needle accidentally touches the disc or after surgery for a disc. The pain characteristics can give us a diagnosis. Severe pain on minimal movement suggests discitis. Pain at night usually can occur with tumors, can occur with infections, can also occur in degenerative disorders where the articular surfaces are inflamed because once the muscles relax, then these surfaces tend to come into contact and produce pain. Pain on standing, it classically because of instability, where there is a slippage of one vertebra over the other, compromising the neural foramen. Sciatica and claudication occur commonly because of disc problems, discogenic, and it can also occur because of canal stenosis, where it is not only the intervertebral disc, but also hypertrophied ligaments and osteophytes, which are producing neural compression. Let's have a quick view over the anatomy of the spine. There are 33 vertebrae, 7 of which are cervical in the neck, 12 are dorsal, chest, and 5 are lumbar. 5 sacral and 4 coccygeal vertebrae complete the spinal column. There is movement in the cervical region and the lumbar region and limited movement in the dorsal region. So disc problems in an acute situation usually occur either in the cervical or in the lumbar vertebrae. Let's have a quick look at vertebral anatomy. Each vertebral body has got bone. There are discs in between. There are ligaments which bind one vertebral body to the other. There are muscles which dynamically support the spine, and there are neural elements. The bone includes an anteriorly placed vertebral body. You have 2 pedicles that come posterolaterally from the body, and then 2 laminae which move posterior-medially. So to complete a ring, which is called the spinal canal. Muscle and ligamentous attachments to the spine occur to the transverse process and to the spinous process. Intervertebral discs are cushions between the vertebral bodies. They have a unique structure with an outer firm covering called the annulus fibrosus and an inner soft gel called the nucleus pulposus. When we talk about disc bulges, we are talking about degeneration of the annulus fibrosus resulting in a bulging. This can also produce neurogenic symptoms, but very often these can be managed without interventions. This prolapse is when there is a tear in the annulus fibrosus, resulting in extrusion of some part of the soft nucleus pulposus. Very often these patients require surgery. Ligaments are very important because if the ligaments are lax, the spine will move abnormally one vertebrae over the other, and this can result in an inflammation of the intervertebral joints. Muscles are something we can work on. Muscle tone, both anterior and posterior, gives dynamic support and can prevent spine degenerations from occurring. Very important to realize that spine exercises which are best for supporting the spine are often static isometric exercises. The plank is a good example. Neural elements which pass through the spinal canal include the spinal cord, which ends at D12L1 junction, and then you have the nerve roots which come down to exit at each intervertebral foramen. This conglomeration of nerve roots is called the cauda equina. How do we evaluate a case of lumbago sciatica? The history might be classical. An older person who complains of pain in the legs on walking, which is relieved on bending forward and on sitting down, likely to have neurogenic claudication and a lumbar canal stenosis. A patient who had a fall, after which backache has persisted, quite possible that there is a fracture. Someone who has lifted a heavy weight, following which he had a click in the spine and later developed sciatica, likely to be an acute disc prolapse. A few pointers in examinations, straight leg raising test impaired, suggests that the nerve is trapped at the level of the intervertebral neural foramen. X-ray of the spine. The deep tendon jerks are important. Ankle jerk absent means that the L5 nerve S1 disc might be collapsed and compression on the S1 root. Motor power, we have already said, L5 root impairment, difficulty in dorsiflexion, and sensory, which is the location, which is the trajectory down which the pain is traveling. It might give us an idea as to which nerve root is predominantly involved. Always check for myelopathy features. Is there, if the reflexes in the lower limb are brisk, even if there is only complaint of lower limb pain, please evaluate the cervical spine also, because we might miss a cervical myelopathy. Imaging includes plain X-rays. An X-ray of the thoracolumbar spine is important, especially in a person who had a fall, because the thoracolumbar junction is the most common site of compression fractures occurring after a fall. The cervical vertebrae are also screened by an X-ray, shows us the loss of curves, and it can show us the degree of spondylosis. An MRI whole spine screen will show us neural elements, disc degenerations, compressions on the nerve. CT spine is important in trauma. It is also important when you are planning to fix a spine, because pedicle anatomy is very well defined and it will show us as to what trajectory a screw should ideally take. 80% of low backache can be managed by lifestyle and exercises. I generally tell my patients to avoid loading the spine, flexion the spine, and avoiding impact. Any weight that you take, the load is transmitted down the spine. Discs tend to get compressed more. Ligamentous laxity results in abnormal movements. So loading should be avoided as much as possible. Flexion, when you bend forward, some of the disc prolapses will increase, because usually the significant rents are occurring in the posterior part of the annulus fibrosus and more nucleus pulposus might herniate. Impact to the spine, we are not talking about direct impact, but impact by jumping and landing. That produces sudden compression of the disc, and especially in a person with a disc injury, that should be avoided. Even going down steps should be done with care. We advise them to walk. Walking provides excellent dynamic muscle toning of the paraspinal muscles. Each step that you take, the muscles are contracting to keep the spine in alignment. Morning 30 minutes of walk will tone up your spine muscles for the day. Hanging by the hands is good because it can give traction to the spine. The weight to the hips and legs provides traction, and this might help relieve some minor sciatica syndromes and even backache. Spine muscle toning, usually and ideally done in an isometric manner, the plank, and there are hundreds of exercises which are isometric exercises for toning the spine. Choose one which suits you and stick to it. Role of medications. Supplements like calcium, vitamin D are important for keeping bone health. Osteoporosis regimes may be required in patients who are osteoporotic. For inflammation, the medicines are given short term only, not to be given on a long term basis. Steroids might help temporizing severe pain. Non-steroidal anti-inflammatory drugs can be used. For radicular pain, you use some kind of anti-epileptics. Gabapentin or pregabalin are most commonly used. What is the role of surgery in spine disorders? Surgery is basically done for two reasons. One is to relieve the pressure on nerves, and the other is to stabilize the spine. Relieving the pressure on nerves can be done by laminectomy, the posterior elements of the spinal canal are removed so that the canal is decompressed. Any hypertrophic ligaments which are compromising the spinal canal can also be excised at the same time, especially a hypertrophic ligamentum flavum. Osteophytes may need to be drilled out if the radiculopathy is because of an osteophyte. Foraminotomy helps open out the nerve root foramen so that the pressure on a nerve is relieved. Discectomy is required when a disc is prolapsed and projecting back into the canal. Stabilization of the spine can be done by pedicle screw constructs. Pedicle screws are passed above in the vertebra above and below, and a stabilization with rods is done, usually with a bit of distraction, to take pressure off nerves and to stabilize that particular segment. Interbody implants can provide additional stability associated with a slight risk of posterior displacement and neurogenic compromise. Other things like interspinous spacers have not stood the test of time. Restoring spinal balance is an engineering solution to a biological problem. In excellent hands, it might provide good results. When we look at a patient with lumbago or lumbago sciatica, we have to consider the bone, disc, ligament, muscle unit. 80% or more of these patients can be managed without surgical intervention, and medication, except for supplements, may have only a short-term role. What are the indications for surgery? If there is neurological compromise, surgery may be required. Cauda equina syndromes, definitely surgery should be done as early as possible. Motor weakness, especially dorsiflexion weakness or plantarflexion weakness, which are most common, early surgery should be done. And severe radicular pain may cause the patient to demand surgery. In back pain, the role is less clear. In some conditions, it is severe pain can be relieved completely by doing a surgical stabilization. Discitis, patient is writhing in pain, not writing, patient can't move in bed because of severe pain. He can't even speak because of spasms. In these cases, stabilization with pedicle screws can provide almost immediate relief. Indications of instability, subtle indications of instability include end plate changes and also ligamentous hypertrophy. The role of surgery in spine is not to make the spine ideal, but to relieve compression and to relieve pain.